afternoon, whatever it might be. I think that people are all over the place. So whatever time you have, it's nice to have you here. So I am going to be talking about reprogenetics. I cannot see all of the images, so I won't be able to see if you raised your hands or if you have questions. So please just speak up so that I know that you are actually trying to ask a question, make a comment, whatever that might be. So this is what I would like to do. I'm going to just do a brief description of what reprogenetic technologies are, the difference between assisted reproductive technologies and then the combination with genetic technologies. So this combination is what it gives us the reprogenetic technologies. Now, I don't know how much you know about these technologies. So, again, it's going to be a brief overview, but feel free to ask questions if you have any questions as I am speaking. So after just presenting a little bit about these technologies, I'll give some of the arguments that have been presented for the use of these technologies and against its use, and then some explicit ethical issues that actually are relevant to reprogenetic technologies in particular. Okay, so let's go with the technologies. So these are just images of different kinds of technologies that are used to allow people to have children. So the reasons for the use of these technologies varies, and we can talk a little bit more about that. But they go from simple IVF, symbol here between quotations, to genome editing technologies. So we'll discuss them a little bit more in detail. So some general information about these technologies so that you can have some framing for the discussion. So about 13 million babies have been born worldwide with the help of these technologies since 1978, which was the first time that the technologies were used. I think this data goes to 2020, so there might be a few more in the last few years. Around 4 million cycles are presumed to be happening every year, and about 1 million babies born. The number of cycles that are performed in many industrialized countries have increased significantly, by 5 to 10% in the last few years. So since the beginning of the use of these technologies of IVF, there has been an increase in their use. There has not been plateau of the use of the technologies yet. Several European countries, including Belgium, Denmark, and Norway, have now more than 5% of all the babies born through these technologies. So a significant number of children are born in some countries, through these technologies. In the United States, this is approximately about 2% of all infants are born with the help of these technologies. You have some references there for this information. A little bit more about these technologies. Europe actually leads the world in the use of these technologies. They have approximately 50% of all reported cycles. Russia, France, Spain, Germany, and Italy are actually the most active countries in the use of these technologies in Europe. And the most official because this is a question of reporting. Who is reporting? And Japan is one of those reported sites. So Japan is the most active country in the world, followed by the USA. But China actually that doesn't have official reporting, but there is some evidence that actually they are performing about 1 million cycles per year. So these technologies. So again, as I mentioned, the technologies are normally a combination. Reprogenetic technologies are a combination of reproductive technologies, so technologies that help people to have kids, and genetic technologies, which help people to have particular kinds of children. Okay, so the genetic technologies help to select or modify, in some cases, with the germline modification technologies, while the reproductive technologies help people have children. Now, not all the people who use these technologies are people who couldn't have children otherwise, okay? Even biologically related children. But many of them use them, because they might be at risk of transmitting some disease, and so they use the technologies to select against certain kinds of traits that they might be carrying. So let's talk a little bit about each of these technologies. So IVF, again, in vitro fertilization and embryo transfer, is the classic technology. All of the other technologies use this one. So, the genetic technologies that we use today are in combination with IVF. So IVF and embryo transfer are the basic technologies. It's a process by which an oocyte is fertilized by a sperm that has been prepared outside of the body, which is why it is called in vitro. The process involves a variety of steps. You have here an image of what is involved. But the basic idea is these technologies, for the first time, when they were used for the first time in 1978, allowed us to actually create embryos in vitro that then are transferred to a woman's uterus so that she can give birth eventually. So the process is complex. There has been a variety of improvements through the years. The success rates of these technologies has improved significantly, though we are still in about the 25% general success rate. It changes depending on the age of the woman. Younger women obviously have higher success rates for these technologies, but the overall is about 25% of success. So one of the technologies that has been developed to improve IVF, to improve the chances that there will be a pregnancy and a live birth, is this ICSI. So in this case, one of the problems might be that the reasons for the infertility is due to low sperm count. So this technology allows clinicians to actually just have very few sperms in one sperm that can be injected directly into the egg. This is the image that you have in front of you, so that fertilization can occur. So this bypasses the possibility that there is not enough sperm for fertilization. So these technologies have a variety of risks, both risks to women and to the babies who are born through these technologies. There has been obviously a variety of studies showing these risks. So there are risks related to the hormones that are used to ensure that there are enough eggs produced so that they can be fertilized. And this can also result in what is called ovarian hyperstimulation syndrome, which can be mild or severe with obviously different consequences. Another risk of these technologies is multiple births. So usually with these technologies, you implant or you transfer more than one embryo for each attempt. which gives rise to the possibility that those old embryos actually implant and you have multiple births. Multiple births have a variety of consequences, obviously, for the health of the woman. And many people have argued that this actually also increases risks to the status of women because it continues emphasizing the role of women as mothers. And this obviously can also create risks for women's lives. There are also risks related to the babies who are born through this technology. So you have, there are some of those risks. The most obvious is those risks related to multiple births. Again, the multiple births is a problem not just for the health of the women who carry the babies, but for the babies themselves. Multiple births come with a variety of health risks for the babies that might be long-lasting in some cases for the life of the children. There is the evidence for the risks, health risks to children born through these technologies is ambiguous. So some studies have shown that actually the use of these technologies increase risks of some health problems. So for the babies who are born through them, while other studies have shown no difference. It's very hard to do research that is well controlled because, of course, many people choose not to participate. There is not sufficient money to do these studies in ways that are robust. So it's hard to arrive to conclusions about their effects. Okay, so those are the reproductive technologies so that help people to have children. As I mentioned, originally, the reason for IVF was to help women who had blocked fallopian tubes. And what this technology did was actually bypass the fallopian tubes to transfer directly the embryo into the uterus. These technologies are now used in many other contexts. So many other reasons for infertility, both for infertility of the female and infertility of the male. And in some cases, there is no infertility. There is simply the reason to use these technologies is that people want to either avoid particular kinds of traits normally related to disease or select for particular kinds of traits, in some cases, sex, for example. So this is an image of Ph.D. that actually allows to do that, pre-implantation genetic diagnosis or testing, different, people call it different things. Screening. So this is an image of that technology. So this is a relatively recent technology. It started in the 90s, early 90s. What it does is you get an embryo, early stages of the embryo, you get one of the cells and evaluate the cells and do an analysis of the genome. Initially, that analysis might have been limited to a particular gene variant, because the parents were carrying a particular genetic mutation. So PGD was trying to ensure that that genetic mutation was not transferred to the babies. But now we do microarray with PGD so that we actually can evaluate thousands of genome variants for all kinds of traits. Again, still the most significant are those that for which there is information about association with diseases, but that need not be the case. And the degree of association with diseases might vary depending on the particular genome variant. They can provide information, as I mentioned, about hundreds of mutations. They might be related not just to disease risks, but to some non-health related traits. Sex, for example, is one of those traits. And the entrance of AI in the clinic has actually brought the possibility of using AI to help with this selection, so that there is an increased use of embryo selection through AI that can look for many traits at the same time and can select among a variety of embryos. So this, is likely to also result in consequences for who is born, in the future. So some risks also related to PGD. One is risks of misdiagnosis, so that you might think that there is false positives, for example, when you're using PGD. This is obviously problematic because there is a limited number of embryos. Every time that you use these technologies, you misdiagnose the embryo as having a particular gene variant associated with disease. You might discard the embryo, which means you have to produce some more embryos to be able to achieve a pregnancy. You can damage the embryos that are biopsied. Remember, I mentioned you have to take one of the cells from the embryo. This can result in developmental problems, and it can actually increase the possibilities that the embryo is actually not going to survive transplantation. The initial evidence regarding children who have been born through PGD is that they show normal developmental compared to children who are born, conceived naturally. It is, however, hard to know what the long-term outcomes might be, because we don't have much data. This is a relatively new technology, and as I mentioned, it's very hard to do studies on this technology. So what the health effects might ultimately be, we don't know. We don't have enough evidence for it. Okay, so some newer technologies, both PGD and IVF. Again, IVF has been used since 78. PGD 92 was when it was introduced in the clinic. They are routine clinical interventions in the context of reproduction. We have some new technologies that actually are not just used to select embryos that would have existed otherwise. What they do is actually modify embryos that have been created through IVF, and you can actually modify some aspects of their genome. Now, these modifications can be either somatic or germline. Somatic modifications actually affect only the individual that is modified. So in these cases, this technology has been used recently, this year actually, to help people who have sickle cell anemia. So they have used CRISPR-Cas to actually develop an intervention to help people with sickle cell anemia. So that's a somatic modification. Somatic modifications obviously have a variety of ethical issues, but most of those ethical issues are similar to those involved with any other intervention, medical intervention. Then we have the germline modifications. Germline modifications affects not only the entity that you are modifying, the particular embryo or the egg and the sperm. You can also modify eggs and sperm. but it has effects on all of the other generations that will be born or that might be born through the use of this technology. So you modify an embryo, that embryo comes to be born and eventually has children. Those children are going to inherit whatever modifications were done to the embryo. And the children of those children will have those modifications also. So these modifications will affect future generations. So germline modifications obviously have had a significant amount of, have raised a significant amount of concern because they affect not only particular individuals, but again, future generations. One of those ways of creating germline modifications is this particular use of the technologies, mitochondrial transfer technologies. These technologies have been used in a context where there is the risk of mitochondrial disease. So in this case, you get the mitochondria, healthy mitochondria from a donor, the egg of a donor that has healthy mitochondria transfer. There are a variety of techniques to do this, but eventually what you get is an embryo that has the nucleus of the egg and the sperm that has created the embryo, plus the mitochondria of a third person, a third woman. There has been only a handful of children born through this technology. Is legal in England, where they had actually a clinical trial where I think 8 children were born through this technology. There had been some children who had been born prior to that, but about which we do not have much information. But the children who were born through this study, during this study, we have more information because they have been followed up. They are, they were just recently born, so we don't know much about, obviously, long-term effects. So that's one type of germline modification. Those modifications, the having different provenance for the nucleus and the mitochondria, that is going to be transferred because mitochondria are transferred maternally. So if children that will be born, female children will actually transfer those mitochondria. The other technology is actually the CRISPR-Cas9, again, a fantastic new technology that can be used for both somatic and germline. It is either illegal or not allowed, even if not explicitly banned, in the overwhelming majority of countries in the world. But in 2018, as you have there, a researcher, he actually used it and created at least 3 babies with this technology. We don't know much about those babies. Again, after this happened, of course, there was an uprising by the scientific community saying that the use of the technology was inappropriate because we didn't have enough guarantees of safety when this technology would be used. So no one has yet attempted, or at least no one that we know of, has attempted to use the technology. We know that some teams are actually trying to create babies born through this technology. And I assume that when they do create one of these babies, we'll obviously find about it if it is successful. Okay. As I mentioned, obviously, these technologies raise a variety of ethical issues. Some of those ethical issues are have been around for a long time, given that these technologies have been around for a long time. The issues that they raise are complex because obviously these technologies involve an activity, reproduction, the creation of families that is essential to human and societal well-being. It's a very important aspect of human well-being and autonomy. So, anything that has to do with reproduction, of the creation of families, is going to raise concerns. They are very powerful, these technologies. Again, they don't simply allow people to have children, they allow us to create particular kind of people. So they give us a significant amount of control. Perhaps not as much as many people think, but a significant amount, certainly much more than we had before. It involves the practice of medicine, with questions about what medicine's goals are. Should medicine be in the business of, helping create particular kind of people? It involves a variety of stakeholders that might have conflicting interests. Among them, obviously, prospective parents, donors of sperm and eggs. Again, many people who uses these technologies actually use donors to create embryos. Clinicians, as I mentioned, they are the ones who ultimately have to help people and have to use the technologies to create new people. And of course, societies that might have different kinds of values and different kinds of concerns related to these technologies. So some arguments that have been given for the use of these technologies. Okay, so one, the most common argument is that these technologies increase reproductive options. So people who cannot have children can use the technology so that they can have it. People who are at risk of transmitting particular diseases are able to use these technologies to create children with whom they have some genetic connection, who do not have those mutations or variants. So they increase reproductive options. They promote parental autonomy. They allow people to make choices about, what children they want to have. And whether they want to have them for those who cannot have them otherwise. They prevent diseases and disabilities. They can be used to select against certain kinds of diseases and certain kinds of disabilities so that people who are born don't have to suffer those consequences. Again, these are arguments that have been offered for these technologies. They ultimately can be used to improve the human species, particularly if we can use them to select against certain kinds of traits that people think are harmful to human well-being. And clearly, if they can help to improve society by improving human beings, making us better, not clear in what sense, but in whatever sense, so that societies can also be improved ultimately. There have, as you can imagine, also been arguments presented against the use of these technologies, a variety of them. Some of them, deontological arguments, ethical arguments grounded on the value of the person. So they have argued that these technologies commodify reproductive material and commodify human beings by treating them as means to someone else's ends, in this case, treating children merely as means to their parents' ends, where parents can choose what is that they think is best for their interests and then create those babies in return. So deontological arguments have argued that this creates a problem for the dignity, for respect for the dignity of persons. Some people have also argued that they actually present a threat to our self-understanding. One of the things is that there is chance in our creation, the kinds of combinations that arise are just the result of chance, while with these technologies we can actually choose particular traits, particular variants, and so that this actually can affect the way in which we understand ourselves as species, rather than the result of chance, now the result of control, the control by other human beings who make decisions about that creation. There are also consequentialist arguments, so arguments about what the consequences of these technologies might be. So obviously there are questions about safety, both for women and for children. As I mentioned before, these technologies come with certain kinds of risks. And so, these are arguments for at least concern for the use of these technologies. Those risks can be both physical and psychological. There are risks to society, as I mentioned, the issue of the devaluing of women by using them as producers or reproducers, the devaluing of children, with the possibility that children might be seen as commodities, increase inequality. These technologies are very expensive. Only some people can use them, which will increase the chances that those people would be selecting for traits that are more likely to give them more chances, and therefore creating more inequality. And this can also affect our conceptions of parenthood. Usually, a common understanding of parenting is the idea that parents ought to accept whatever child they have. But with these technologies, the issue is not to accept whatever child would have been born, but with creating particular kinds of children, which I can accept because they have those characteristics. And of course, many people argue that these technologies are just the beginning of a slippery slope. We started using them only in a very limited context for women who couldn't have children because of fallopian blockage. We use them for all kinds of reasons, with no infertility involved, with infertility involved in the context of the woman or the man, and of course, to modify embryos because of certain traits that we desire or that we want to eliminate. Okay, so let me finish with some specific issues, some questions, so that maybe we can have some time for discussion. So some questions for all of you. So some specific issues, is how much power should prospective parents have over their children? So this is a significant question that we need to answer. What are the limits of parental autonomy? How much control should parents have over who is born and who is not, given again that this has consequences not just for their own family, but for society in general? Some people have argued actually that because these technologies can allow us to eliminate certain kinds of diseases and disabilities, then prospective parents are actually morally required to use them, so that if they are at risk of transmitting diseases and disabilities, they would avoid doing so. This is obviously an argument that has received a significant amount of attention. It's quite controversial. This is a eugenic argument. We ought to eliminate, and people have a moral duty to do so. So what are the moral obligations of clinicians? Do clinicians have to participate in these kinds of uses of the technology? Is this consistent with the role of medicine in our society? Again, this issue of about how much power should prospective parents have. Many people say, as I mentioned, that they should be selecting against disability, but there is a significant amount of criticism about this argument. Why should we be selecting against disability? The disability community, for example, has presented a significant critique of these arguments. That is very important. And of course, one of the questions that they raise is what disabilities should we be targeting? Again, this is a concern also with the slippery slope. The same about if the issue is that we should allow people to make the choices that they want according to their preferences, then some people might actually desire to have disabled children or what are thought to be disabled children. For example, this has been an argument in the deaf community. The deaf community, they don't see themselves as disabled, or many of them don't see themselves as disabled, so they might want to create children who are like them, just like parents who are not disabled want to have children who are not disabled. So if we have arguments for promoting parental autonomy, then it would follow that we should allow these kinds of uses of the technologies. And again, we will have the use, question about what disabilities will be allowing to create. And so most people are okay with the use of these technologies to select against at least some diseases and some disabilities. But the question is, what about selecting for or against traits that are not related to disease? People being taller, shorter, more beautiful, smarter, whatever, any traits that one might wish to enhance. This is what is called the enhancement argument. Can we use these technologies not just to prevent disease, but to enhance the human species? And of course, again, the issue is what traits are we going to be using these technologies to enhance them? Again, the question of are prospective parents morally required to use these technologies, okay? If it is the case that we owe it to our children to create the best conditions possible for them to increase their well-being, then some people have argued, one of the articles that you have, actually, the Sabulescu article, where they argue that actually there is a moral requirement to use reprogenetic technologies. And of course, again, we have here the questions of, do we use them only for selection purposes? So people who would, would have been created, that eliminate certain kinds of diseases and disabilities, or for enhancement purposes, so to select for traits that have nothing to do with disease and disability. Again, what are the moral obligations of clinicians? In this case, again, can they refuse if prospective parents come and they want to select or create embryos that are taller or smarter, or again, whatever might be? So can clinicians refuse? And if so, on what grounds are they going to refuse? Can they encourage prospective parents to use these technologies? For example, prospective parents who might be at risk of transmitting certain mutations that are correlated with disease. Should clinicians insist that they use Ph.D so that they can select against those variants? So here you have some references, for much of what I had discussed here. And again, I had sent some articles also. And I wanted to leave a little bit of time for questions. So let me stop sharing now. so that if you have any questions, comments, concerns, I'll be happy to. We have 10 minutes or so to discuss. So. Anybody has any questions? I don't know. Again, I don't know how much you knew about these technologies. Of course, there is much more to discuss about them, but given the limited time, this is a general overview. Nadia, yes.
Nadia from Morocco. I have just a comment. You have a question about how much parents have power on their children. I have a comment. What do you mean by children or prospective children? A non-brain is what? Is a future life? Is a material genetic? Is biological genetic? We don't know. The definition of the non-brain is not very clear, I mean. And I have also another comment. Should the parents use reproductive genetic? I mean, it will be a lot of discrimination. If I am as parents, I have enough money to use reproductive genetic. I will have the perfect children without any disabilities. In contrast, parents from underdeveloped countries will have a lot of disabilities. And so pharmaceutical companies wouldn't have any research about disabilities because rich children wouldn't have any disabilities. It will be a lot of problem, I mean.
Yes, indeed. Thank you for those comments. Yes, as I mentioned, one of the arguments against this technology is the increasing inequalities, precisely because these technologies are very expensive. Only some people can use them, and those people obviously would be able to select against, again, diseases and disabilities that then people who are conceived naturally would not be able to prevent. It's a powerful argument, but it is not an argument that many people have found convincing because they say this is the case for any medical intervention. Many medical interventions can be used only by people who have money and cannot be used by other people. So if we are going to prohibit these technologies on those grounds, then we also have to prohibit many other technologies. So people who have defended the use of these technologies have argued that actually what we ought to do is to ensure that these technologies are accessible to everybody who use them, who would want to use them. Now, I think that argument is pie in the sky, given the expense of these technologies, but obviously that would address this particular concern, the concern about access to these technologies. Regarding your other comment about the control over the children, it's true that the control that you have, the immediate control, is over embryos, and embryos, are not children. But the reason to have that control over the embryos is eventually those embryos might become human beings, might become persons. And then the control is obviously over those individuals. So yes, the embryos are the means of that control, but ultimately we have control over who is born and who is not, what characteristics they have. Thank you. Pascal. I don't know. Yeah, you have your hand raised, but I don't know whether you want to ask a question.
Pascal Aneke from Nigeria.
Okay.
Yes, I want to ask a question. Yeah, thank you. Let me say that it's a comprehensive lecture that touches deeper aspects of reproductive genetics. I was with you in 2017 at Pace University. Personally, we are together. I listened to you. I came to US then. So what I want to ask about this is that on what ethical basis are we going to opt for reprogenetic technology? For example, let me come from the point of view of religion. Like I'm a Catholic, and the Catholic Church teaches us that third-party intervention into reproduction is wrong. It's unacceptable according to the doctrines of the Catholic Church. But traditionally, as an outcome, that means there must be children to continue the genetic, the ancestral linkage. So when this such desire of one's heart, which is culturally sanctioned, is confronted by such tenets of religious belief, so there comes a conflict which often push people to opt for illicit pathways to parenthood, just like baby selling, beef factories, and all those illicit pathways to parenthood. But people choose to believe or accept what they see to be ethically justified. So, like, if we want to apply ethical theories to this, do we go the way of situation ethics when our desire to have children is confronted by prevention? So what will be the best ethical argument that will help us in this situation? Thank you.
Yes, thank you, Bashar. I couldn't hear everything because there was some interferences. But as I mentioned, the arguments for or against the use of these technologies are complex, and again, we have been arguing for and against, since 1978 when these technologies were actually created. At the beginning of the use of these technologies, the most significant arguments against these technologies came actually from a religious point of view, as you were mentioning. So there were arguments that were against what reproduction is supposed to be for, that were arguments that were technologies that actually influenced our conception of what a family is, and of course that were against the divine giving of children, that these technologies were bypassing that divine power. Of course, many people are not religious, and if we are going to present arguments that are compelling to other people, who might not be religious or who have different religious beliefs. Again, different religions have approached these technologies in different ways. Some accept the use of these technologies, while others, the Catholic Church, for example, opposes the use of these technologies. But that's not the case for all religions. So the arguments that, certainly philosophers find or try to present are arguments that would be appealing to a variety of views that have something in common in many cases, again, with religious beliefs, but that are not religious at nature. So again, both from a religious point of view and for a non-religious point of view, you can find concerns about the use of these technologies. And as I mentioned, you're asking, from a religious point of view, what arguments do you have against these technologies? And the Catholic Church, for example, has presented very strong arguments against the use of these technologies. Still today, do not accept the use of these technologies. More questions, comments?
Yeah, I comment. So if my understanding of this progenetic choice, progenetic technology, if we have to make decisions for the kind of children that are born, does that mean we have to take decision? We have to take responsibility for also what they become in life. For instance, we have made a choice. We made genetic choice and say this is the kind of child I want. So by the time the child becomes whatever it becomes in the society, good or bad, are we going to be held responsible for their decisions too?
Yeah.
Thank you.
Yeah, that's a great question. Yeah, I mean, this is the issue. With power comes responsibility. So, insofar, this has been an argument that has been presented also from the deontological point of view, as I was mentioning before. The argument about, focusing on the dignity or the treating people as ends and not just as means. When I choose, I am responsible for those choices. If I have a child about which I don't have any control, what child is born. Obviously, I have a responsibility when I choose to have a child. That's a choice in many cases, not always, but in many cases. But here we have control not just over having a child, but over having a particular kind of child. So, of course, one of the issues is responsibilities for those choices that we have made by using those technologies. And one of the interesting things about at least, some of these technologies like genome editing is that we don't know the consequences because these technologies have not been used, and the only way to know what the consequences are is actually using them, which might mean obviously to create significant problems for not just individuals but the human species. So yes, questions about the responsibility of prospective parents are very significant. This is why, again, most people, who are proponents of these technologies, they argue that this increases reproductive choice, but reproduction is not an individual activity. It has significant effects, obviously, on the people who are born, but also on society. So it seems a weird argument to say that only prospective parents should have a say about what these technologies should be and how they should be used. I think we are out of time. I mean, I'm happy to continue the conversation, but I know that you have another talk right now, I think. Anna, right? You are muted. Anna, yeah.
Yeah, sorry. Yeah, am I okay right now? No, Professor Jonathan Moreno is gonna show up at 1 p.m.
Okay.
And because
so we have a few more minutes then, if anybody wants to have.
If you can, if you have time.
Okay.
And thank you so much.
Any other questions or comments?
Yeah.
I have a question. Why those technologies are so expensive currently, and if there is a perspective to decrease the cost, because I think it's important about the evolution.
Right. Well, what makes them expensive is that they are very complex. IVF is the technology that creates the expense. Genetic technologies that are used in combination actually have come to have the prices have been reduced significantly. They were very expensive initially, but now it's very easy to do testing for, again, hundreds of variants. But the process of IVF, from the creation, the production of eggs or of the ovarian tissue to the sperm treatment, to the creation of the embryo, to the transfer of the embryo to the uterus. All of this is, involves many people, many clinicians, many researchers, and the prices have not come down significantly since the beginning of the use of these technologies, again, a few decades ago. So although it's quite likely that the genetic technologies are not going to increase the costs significantly, it is also unlikely that the prices of these technologies would come down.
Yeah, I do have a question. Inmaculada, we're friends with Fred Licciardi, who is one of the best fertility expert in New York area. So what's the price actually for a fertility treatment right now? You might know. I used to research that, but things have changed quite a bit since a couple of years ago.
Yeah. So, this is the interesting thing, it depends on what you want, what the price is for. So the price of a cycle of IVF is $4,000 to $5,000. But rarely there is a pregnancy after one cycle. So there was an article recently on the amount of money that some couples spend, and they can spend thousands and thousands of dollars in actually trying to have a child. Sometimes they end up having it, and sometimes they spend thousands and thousands of dollars and they do not have a child. So the average for, again, people who do at least a couple of cycles, that increases the chances of having a child, is about $10,000. So it's expensive, obviously. And again, the majority of people don't have a child when they try the first time. As I mentioned, the success rates of these technologies is about 25% on average. So many people are using, as I was mentioning, age is a significant risk for the success of these technologies. So younger women obviously have more success than older women. Older women have more success if they use donated eggs, so that come from younger women. So all of those things obviously change the costs. But again, the average is $10,000, and it's very rare for someone to have a child after just a couple of tries.
Yeah, there are all sorts of cases, right? There are articles and there are mentions. People sell their houses and they're trying and
Right.
they divorce and then they're married.
Yeah. They were, again, this article, I think they had to spend I think it was $200,000 to try to have a child. And so many people go into debt to have a child, to use these technologies. In the United States, some insurance companies might cover at least some cycles. There would be a variety of conditions, but they might cover, very good insurance.
But there is an age limit, right? Isn't it a
there is an age limit in many cases.
Yes.
Yeah, there is a how many times you can try limit. So there are a variety of limits. Again, not all insurance companies would cover it. Some do. In Europe, most countries have IVF as part of the state healthcare system, but there are significant waiting lists, which means that, if people, again, age is a significant reason for infertility, so you don't want to wait forever. And so many couples actually go to private clinics to do IVF because they cannot wait in their, in the healthcare system. So even in countries where this is covered by the healthcare system, still there are significant differences about who can use them.
Yeah. Thank you so much. I think I hear some noises. Hello.
Okay.
A participant, hello, please pay attention to this if you don't mind. All right. So before you leave, if there are no more questions,
I think
we would like to take.
there is a question on the
I have
chat.
a question in the chat box.
There's a noise over there, please. Participants, I would like
to. There was a question, Anna. I think there is a question.
Yeah, there is another question. Go ahead. Someone said there is a question. Was that Vasile?
The question is posted on the chat, and the question is from Isokan. There are indications that some people go through all this and still don't have a child, and they could also develop health issues. This is the question. Is there any research to justify the connection of these hormonal interventions to cancer? So two questions.
Yeah, that's a good question. Yeah, indeed. People, women who are the ones obviously running the risks. They are women, the ones who go through the hormone treatments, the ones who go through the transfer, and of course the ones who have the babies. And indeed they can do all of these many times and still have no child. But even if they do have the child, there has been questions about the risks, health risks related to the use of these technologies. There has been research done on actually the relationships between the hormone treatments and cancer, and the evidence is unclear. So some research has shown that there is an increased risk of some cancers, particularly reproductive cancers, breast and uterine cancer, but other research has not shown correlation with the hormones. So it is the case that women who use these hormones have an increased risk of cancer, but the issue is that they might have that increased risk for other reasons that might be related to their infertility, actually. So it's very hard to separate different variants, different reasons for why this increase in cancer might happen. But indeed, there is research that indicates that there is an increased risk of cancer, but it's not conclusive.
And if there are no more questions, we would like to thank you so much. And thank you so much for your support over the years. Thank you so much for your wonderful friendship. Wonderful friendship. We have to come to Spain and have a school there.
Absolutely.
But I don't know where this is going to happen. And I would like, hello, there's something. I would like you to stay with us to take a couple of photos. And I would like to ask the participants to turn on the cameras. Those who wouldn't like to do that, they won't be in this photo. So we have a tradition, so to speak. We always take photos with the group, but please, not to the hand like this, not with the hand like this, and please don't scratch your nose. I'm kidding. Yeah, of course. Sorry about that. Don't do that. So now, who's going to take a photo? We have our expert here, is Vasile. He's one of my right hands, and some other people too. So let's take a nice photo. Now, Eman, you cannot turn on the camera, but you have a photo there. You always have the same photo as I see. All right. She was taking the course last year. All right. So thank you so much. And you smile. And then a couple of them, Linda, if you can take a photo, you are, how to say, invited to do so, or some other people who are good photographers. Please turn on the cameras. So Vasile, are you going to do that?
I took a print screen. I sent it to the chat to all of you.
Yeah, but we want a photo with the group.
When you say photo to the group, what exactly?
That means the whole group and Inmaculada on the right corner or on the left
let me
corner.
see. One second.
Like,
one moment. Yeah,
like gallery.
Yeah,
now, here we are.
Right.
See?
Yeah.
You hit the gallery, and Nadia, your face a little bit.
Yeah, it's fine. I will take another one. Give me 1 second.
Smile. Peter, if you don't mind, your head should be a little bit towards the wall. Can you hear me?
Okay.
No, Lean. Hello, Lean. Where's Lean? Turn on the camera because it's not.
Is it on right now?
Yeah, but there is a black spot near you. Why?
I'm not sure.
There's a black spot near
there.
Pascal.
Yeah, there.
Okay. All right. There is a black spot near Lazaro. If you don't want to be in the photo, no problem. But I see a black Lazaro. Lazaro, please. That looks terrible. Is the guy there? Hey, hello. Charlotte, bonjour. She's always, Charlotte, if you want, you can take a photo too. So the more the better. Isoken is her name? She disappeared.
Yeah, I'm here, but I've been having issues with my camera. I've been
okay. Why are you there? And I see, please, if you. All right. And Lazaro, okay. Where are you? Okay, guys, it's very difficult for us to edit all these black spots. For you to know, I'm sorry, I'm picky. I'm sorry, I apologize, Inma, for this. But we need professional, nice photos. Okay, good. So Nadia, my friend, your head a little bit back. Can you, Nadia? She's sweet. No, not towards the screen. Back. Okay, that's it. Thank you so much. Hello, Kathy. I haven't seen you in a while. You changed your coiffure. Okay, thank you. Okay, is that good? Mr. Vasile, the expert, did you take good photos?
I hope the best ones. Yeah.
Okay, good. All right. So Inma, all my love. And thank you so much.
Thank you.
And we're going to be in touch. I know you're very busy. I wish I could fly to Spain, but it will happen.
Would be nice.
Yeah.
Thank you, everybody. Have a good rest of the day or the evening or whatever it might be.